Let's start with the first case, standard phacoemulsification for, let's say, standard cataract. This is the way how the OR looks when I'm using the Ingenuity machine. So this is the OCT in front of me, a bit to the left-hand side, and the Ingenuity. I'm using the phacoemulsification machine, the Leica 844 microscope, either with binoculars or with intraoperative OCT connected to microscope and the Ingenuity system. And I am prepared to perform a standard phacoemulsification surgery. Here I'm using the binoculars of the microscope, and here I'm using the Ingenuity system. There are three visualization possibilities, either on the OCT screen itself, which is in front of the surgeon here, or you can have it in picture of the Ingenuity screen, and you can use them in either of the four corners of the Ingenuity screen, or you can split the Ingenuity screen in two, and half of it you have the surgery image, and on the other half of it you have the OCT image. Or you can use them both, like in this case. I have here the EnFocus screen, and here I have one picture-in-picture image. In terms of cataract surgery, to be honest, I don't notice too many advantages using it in standard cases for the surgical technique itself, but I'm sure it is useful, and I use it for teaching purposes, for scientific purposes. For example, you can watch the wound architecture, the phaco position, the fluctuations of the anterior chamber depth, the zonules behavior, the iris behavior, and so on. And I think it is also quite useful in special, or let's say complicated cases like this one, in mature cataract with no red reflex, in posterior polar cataract, for sure it is helpful because you don't always assess the depth and the thickness of the lens. In posterior capsule rupture, in zonular rupture, subluxated lens, small pupil, and also in IFIS syndrome, you can also watch the behavior not only of the zonules, but also of the iris, which is floppy. And this is a case of mature cataract with relatively small pupil, and I'm using the EnFocus image in a picture-in-picture, bottom right corner of the Ingenuity screen. It helps me in visualizing the position of the posterior capsule. Let's go further. Let's go on to the second case. It is also a cataract surgery, but a complicated one. I'm talking about a 62 years old male with an advanced cataract, finger count, pre-op visual acuity, no other eye pathology. I had planned to use a standard chop phacoemulsification and PCIOL implantation, but at the very end of the procedure, when I attempted to hydrate the paracentesis, I saw a strange line, slightly curved, thin line, which I presumed it was a descendant membrane detachment. Accidental detachment, of course. I immediately asked for the EnFocus OCT, and I had the confirmation. Indeed, the OCT showed me and helped me in assessing the detachment extent of the descendant membrane. And it also helped me in solving the complication by injecting air in the anterior chamber, as you will soon see. So this is the surgery. I'm at the end of the surgery, and this is that tiny, fine line highlighted by the red arrow, which I presumed it is an accidental descendant detachment, and indeed the EnFocus confirmed me this incident in 1/3 or almost 1/2 of the descendant. I injected air, but it was not enough. The EnFocus helped me in showing me that it was not enough. I injected more, and at the end, I checked once again with the EnFocus OCT, and indeed it was, at the end, I could see that it was really attached, completely attached. And this is the second case, complicated phacoemulsification as well. But in this case, I have patient with cataract on corneal transplant, penetrating graft done several years ago. The surgery went very well. It was done with help of the femtolaser technology. The lady was prepared to receive a toric IOL, which it happened. And at the end of surgery, I need to go a bit, it is a heavy, let's say a heavy video, so I really need to show it to you once again. When I attempt to hydrate the main incision, look here, you don't want to miss it. Look how this circular line, and I assumed it was decimate, accidental decimate detachment, and indeed the OCT showed me that it was almost, let's say, 90% of the decimate, it was detached. I solved the problem in a similar way like I did in the previous case, by injecting air. And to the third day post-op, the cornea looked quite nice, a little bit of edema, and 3 decimate folds in which some blood from the main incision entered. 2 weeks post-op, the cornea was clear, no more edema, as you can see clinically on the anterior segment photography and on the anterior segment OCT. But there were still those 3 small folds in the decimate filled with blood, but with good best corrected visual acuity. And 3 months post-op, the cornea looked perfect. So the graft, the penetrating graft, which was severely injured by my accidental decimate detachment at the end of the cataract procedure, this graft looked perfectly. The best corrected visual acuity was 0.9. We had a clear cornea, completely attached endothelium and decimate membrane, no other issues. Let's go further to the 5th case. This is a male, 72 years old male with a rich history, eye history. In 2017, he had a failed cataract surgery in another clinic, finished by implantation of an anterior chamber IOL, bullous keratopathy, and secondary glaucoma. He came to us with a painful eye, very low visual acuity, hand movement, and high IOP. In 2018, after obtaining a lower IOP with medication, we proposed him for a combined procedure, anterior chamber IOL explantation, anterior vitrectomy, and penetrating keratoplasty. But we preferred to leave this patient aphakic because we were afraid of new rise in of the IOP, and also we didn't know the potential of this eye. And we said, first of all, we need to keep a low IOP and to have a quiet eye with no pain and a clear graft. And indeed, between 2019 and 2021, the visual acuity was satisfactory, 0.3 with plus 11 and a normal IOP. In 2022, he was supposed to receive posterior chamber IOL sutured at sclera, but we noticed the drop of the visual acuity to 0.1. And we performed an retinal OCT, and we discovered an epiretinal membrane. So we took the decision to perform a combined procedure, secondary PCIOL, fixed at sclera, and the epiretinal removal. So that was the plan, to use the Constellation for the posterior vitrectomy, to use the Ingenuity visualization system, as we always do in our posterior surgeries, and of course the EnFocus intraoperative OCT attached to the microscope. The surgery has been done by our colleague, Dr. Lucan Michev. He uses 3 trocars of 23 gauges, and he removed the epiretinal membrane under blue dye, dual blue, in his and our standard procedure. And then he implanted a Carlevale IOL, fixed a sclera under scleral pockets, and we use the EnFocus OCT not only for checking the macula, but also for checking the position, the correct position of the haptics of this Carlevale IOL. So this is the lens. You can see it in the picture at the beginning of the video, and again we have a busy slide, so allow me to enter in this way. Maybe it will function better indeed. Let me see if I'm if the things are going. Yes, sorry for that, but this is a heavy heavy slide. This is the eye at the beginning of the surgery. Now the RMA is completely, a retinal membrane is completely removed. So now we are focusing, Lucan is focusing on the implantation of the Carlevale IOL. He already performed the two lateral scleral pockets, as you see. And because they are pockets and not flaps, he doesn't really see, the surgeon doesn't really see the position of the haptics. So that's why we found quite very useful using the OCT, intraoperative OCT, in checking the final position of the two haptics. Here on the left side haptic, and then you can see here under the flap, under the pocket, sorry, the very well and correct position of the haptic on the right hand side.